Dr. Walker to share with you his insights about when imaging may or may not be required. I think this will be extremely interesting as well. Dr. Walker is an associate professor in the Department of Radiology and is a member of the McCaig Institute for Bone and Joint Health. After graduating and completing residency training in family medicine, he practiced primary care in Northern Saskatchewan for a couple of years, and then following that, he completed residency training in Diagnostic Radiology at Boston University School of Medicine. His primary research interests include multimodal imaging of sports-related injuries and joint trauma, imaging appropriateness, and quality improvement. Dr. Walker spent 5 years as clinical and academic head of radiology at the University of Calgary and has consulted for not only the World Junior Hockey Championships, but volunteered at the Vancouver Winter Olympic and Paralympic Games as a radiologist. Ladies and gentlemen, please welcome Dr. Walker.
Thank you for that kind introduction. It's really wonderful to be here and to present to you the title of my talk, MRY, Be Imaging Informed. I have no relevant disclosures. Sorry, it's a habit. In 2010, the fellows and members of the Royal College of Physicians and Surgeons of Edinburgh voted on what the top 20 most important medical developments were in the last 50 years. I don't think anyone would be surprised to see antibiotics at number 1 or perhaps vaccinations at number 2, but I bet many are surprised to see imaging at number 3. And the caption reads, "The development of CT and MRI scanning has revolutionized the manner in which the body can be scanned in order to detect disease and inform treatment and a range of disease areas." And it's absolutely true. Computed tomography, or what we refer to as CT, or magnetic resonance imaging, or MRI, has had a profound impact on healthcare and medicine. Here are 2 examples of the exquisite detail that you can see with modern imaging. On the right side here, this is a micro CT scan of a study knee participant who has an ACL tear. This was performed at the McCaig Institute. And the resolution on this is 63 micrometers, which is only slightly thicker than a human hair. On the other side, this is a complete spine MRI in a patient with inflammatory back pain or ankylosing spondylitis. And as shown here in the red ovals, there is inflammation in the spine as well as by the curved arrows at the interspinous ligaments. And it's important because MRI has such ability to pick up detail that we can see inflammation that will not be visible on radiographs, and it's very important in the management of these people with this disease. So MRI, why? When should an MRI be performed? And when is an MRI likely not required? So we'll talk about over the next 12 minutes. So a few facts about knee osteoarthritis. It affects a lot of people, 240 million persons worldwide, and the hip and the knee are the most commonly affected joints. Symptoms include pain and stiffness, often worse in the morning or after prolonged sitting. Typically will start to improve after some activity in 30 minutes. The diagnosis, the provisional diagnosis, can almost always be made on history and physical exam, and it's an X-ray that is the imaging modality of choice for the assessment of osteoarthritis, usually confirming the diagnosis and also giving us impression of the severity of the damage of the knee. Now, it's important to note that the X-rays do not always correlate with the severity that we see or that a patient experiences. So it might be that someone has very severe looking X-rays and bad arthritis on their X-rays, but actually they don't have many symptoms. And the corollary is true as well, that people may have quite severe symptoms, yet not severe X-ray changes. One thing that is a quote directly from this article by Katz that was published in the Journal of the American Medical Association, magnetic resonance imaging is seldom indicated in the assessment or management of knee or hip osteoarthritis. So I'll speak a little bit, twice I'll comment about Choosing Wisely Canada. Now, Choosing Wisely Canada is a campaign that encourages informed discussions between patients and clinicians or primary care providers around tests, around treatments, and around procedures related to their health. And in 2018, the Canadian Orthopedic Association released 5 new recommendations. And interesting, the first 2 were related to osteoarthritis of the knee. The first, don't use arthroscopic debridement as a primary treatment in the management of osteoarthritis of the knee. The second, don't order a knee MRI when weight-bearing x-rays demonstrate osteoarthritis and symptoms are suggestive of osteoarthritis, as the MRI rarely adds useful information to guide diagnosis and treatment. So let's look at that a little bit further. So here, similar to what Jason showed, this is a normal x-ray on the right, and this is an osteoarthritic x-ray on the left. Or pardon me, on the right, osteoarthritis, on the left, a normal x-ray. So the question, my knee hurts, it could be osteoarthritis. Do I need an MRI? Well, if your knee hurts and this is your x-rays, it might be reasonable to perform a knee MRI to look for a soft tissue abnormality that's causing your problems. However, if your knee looks like this, which demonstrates severe medial compartment osteoarthritis, worse on the left, and if your symptoms are in the medial aspect of your knee or the inner part of your knee and are consistent with osteoarthritis, I would say an X-ray, or pardon me, an MRI is not indicated. Now here's an example of a normal MRI of the knee on the left and an osteoarthritic knee on the right. And if we look at these circles, this is what the knee meniscus looks like, this triangle here. But you can see in the osteoarthritis knee, it's abnormal. It's actually been pushed out of the joint because of the arthritis. And it's interesting that that is probably not what's causing the patient's symptoms in this example. What a lot of researchers feel is that the osteoarthritis pain relates to these changes, which is edema or swelling in the joint. We call them bone marrow lesions that cause the symptoms in osteoarthritis. So what would be the drawback of having an MRI of your knee ordered by a primary care provider if you had moderate to severe osteoarthritis? Well, the first might be that while you're waiting for that MRI, it may delay implementation of effective treatment strategies. And Jason spoke about many of the effective strategies: anti-inflammatory medications, strength exercises, weight modification, if that's appropriate, non-surgical interventions, which might include bracing, or even a surgical assessment and maybe a knee replacement. Second, meniscal tears are common and may not account for knee symptoms, as I showed you previously. And we've shown from the Canadian Orthopedic Association that they do not recommend arthroscopy and debridement in these cases. And finally, the sensation of instability, or that your knee is giving way. Many people may think that relates to a tear of a ligament within their knee, but often in the setting of osteoarthritis, it relates to weak quadriceps. So I'm going to change gears a little bit and now speak a little bit about back pain. It'd be no surprise to anyone here that back pain is common, and about 3/4 of the people in this room will experience an episode of back pain at some point in their lifetime. It's interesting, the risk factors for back pain or low back pain are quite poorly understood. We know that physical work, frequent bending, twisting, or pulling can sometimes be associated with back pain. We also know that there are psychosocial risk factors, including stress and anxiety, that correspond also or participate in low back pain. It turns out there's a lack of correlation in patients' symptoms and MR findings in back pain. So this was a very nice study. It was out of the Seattle area, and they got almost 150 people, and these people had no back pain. And they did an MRI on them, and then every 4 months, someone would call them and ask them specific questions of whether they had back pain. And then at the end of 3 years, they did another MRI. And interestingly, when they looked at those people over that 3-year span, many of them would develop back pain during that time, but if you looked at their MRI before and their MRI after, most of the time it had not changed. They still had some of the changes that they had before when they had no pain. So lack of correlation between patient symptoms and MRI findings. Finally, it's been quite well shown in the literature that acute low back pain is usually self-limited. There's a guideline from the European Guidelines on Primary Care that states 90% of people will recover within the first 6 weeks. There was a meta-analysis that was published in 2012 in the Canadian Medical Association Journal, and it stated that the typical course of back pain is favorable. And so I think a general statement that would be true would be that the majority of people with nonspecific low back pain will recover within the first 6 weeks. So I spoke about choosing wisely earlier. So the Canadian Association of Radiologists and the College of Family Physicians and Surgeons actually share a recommendation within choosing wisely. And it states, don't do imaging of lower back pain in the first 6 weeks unless red flags are present. So what are red flags? Well, red flags are clinical symptoms or signs that could indicate serious disease. They might indicate the need to see a surgeon or even the need to have a surgical procedure performed on your back. So what are red flags? Well, signs that might indicate a compression fracture, signs that might suggest that there's a risk that this could be cancer, which in the published literature is probably about 1% or less of people presenting with low back pain. A spinal infection is very rare, and I showed you previously an example of inflammatory back pain or spinal arthritis that can also cause back pain. Now, this is an example of what spinal infection looks like on an MRI. So on these T1 weighted images, there's edema within the spine and there's loss of the joint space, but if you look here, this is after they've injected contrast, and the whole vertebral bodies, the L1 and the L2 vertebral bodies, enhance because of infection and inflammation in those joints. So I'm going to conclude by a little bit of a clinical vignette. It was the COVID-19 pandemic. This individual, like many during COVID-19, had put on a bit of weight. We called it the COVID-19. And they were trying to get back into shape, and so they were in their home gym doing some pull-ups, and they had a sudden onset of neck pain and left arm tingling and numbness, so sensory symptoms in the left arm. They tried conservative management for almost 4 to 5 months. They did non-steroidal anti-inflammatory medications, physiotherapy, and despite that, their symptoms did not improve. And in fact, one day, when trying to lift their work bag into the back of their trunk, they realized that they had lost the strength of their arm. They could not lift their bag. And that's actually when I realized that my symptoms were probably not going to get better and that I needed to do something different. So I saw a neurologist. I ended up having an MRI. And this is a picture of that MRI. And so these are the white arrows here point to this disc herniation that's compressing my C5 nerve root, which would make sense when I've got arm weakness and numbness. This is what the normal neuroforamen would look like. I saw a surgeon and ended up having a discectomy and a disc replacement in my spine. Now, I'll confess, I don't usually tell 100 or 150 people about my medical story. But I think it's important to know that as someone who reads MRI for a living and understands the detail that MRI can see, I followed the guidelines. I knew that in the majority of the cases I was going to improve, and I gave it time to improve. I did what I could, but when my symptoms didn't get better or when they got worse, that's when I got referred on to see a specialist and had an MRI. So in summary, question, my knee hurts. It could be osteoarthritis. Do I need an MRI? My recommendation would be get a standing X-ray of the knee, And if that X-ray shows moderate to severe osteoarthritis, an MRI is very unlikely to add benefit to your management and is not indicated. The next question, I hurt my back. Do I need an MRI? There, the recommendation is, well, that depends. But I will say that an MRI is likely not indicated if the duration of your symptoms is less than 6 weeks, when there are no red flags, and on history or suspicious findings on clinical examination. So thank you for your attention.